Hey, Omar, can you hear me?
So
Hey, how you doing? You coming?
I am ready now. I am at Termani Siri Adlib.
Oh, okay. It starts in 30 minutes, okay?
Can you the link?
Yeah, I'll send you the link.
Okay, thank you very much for you.
Yeah, okay.
喂喂喂，能听到吗？
啊，听见，听见。
Hello, Dr. John.
Hey, hello, how you doing? Is that Omar?
I am Omar. I am ready.
Oh, you got in, huh? So you're speaking tonight?
I am my friend here beside me. I am at his house.
Oh, okay.
Near Idlib. Near Idlib. Mhm.
No sé si hay internet o qué se llama. ¿Tu papá probó el Aneurysm? Pero le di con pan. ¿Qué dijo? Con pan. O sea,
We start in about 18 minutes.
Ese Zoom. Que no le pongo mensajes. Que ahora estoy escuchando a la gente hablando.
Well, tip me over with a feather, Joanna. Joanna?
Hi, John.
Joanna, how are you? It's late for you over there, right?
I know. It's really late.
Okay, you feel like working? You want to be the co-host, Joanna? Hello?
Sorry, what did you say?
Yeah, you want to be the co-host?
We have co-host today, Dr. John.
I guess you didn't hear me, Joanne, right? But that's no big deal. Don't worry about it. Don't worry about it.
Co-host today.
I'm sorry, Omar, what did you say?
There's co-host today. For the co-host today.
I don't understand.
The program co-host for keys for question.
Oh, yeah,
Co-host.
I believe, they're going to determine the structure, but I believe, yeah, that's part of it. Questions.
Okay, I am ready.
Questions.
Mr.
And
to
they're
make
going to
the
run that.
review.
I'm not going to run that. I'll basically just turn it over.
Okay. This morning.
Well, this is a big step. I'm gonna change the background. They don't pay me for nothing. It's- We start in 10 minutes. See, we have a lot of Oriental neurosurgeons on the panel. Yeah, I think I can hear someone snoring. I don't know who it is. I can hazard a guess. Okay, I gotta remember everything important here.
I'm ready. How are you?
Okay, you're ready, huh, Omar?
Oh, okay. For the power, there's no electricity here. It's power for the mobile, power only.
You're calling from Syria, right, Omar? That's you.
I think-
You're the
Yes.
only guy that ever been on here from Syria that I know of.
Yes. It's from Syria now.
So it's Wi-Fi, right?
I finished 2 operations today. I now finished. Come to here, near village near Idlib, Dana and Termani, if you know, at the Google Maps. Here too much Asian, Roman building.
There's
Too much
Lee.
Asian. Here at Termanin, at Syria, I am in Termanin now. There's too much Asian, old people, old building.
Okay,
Germany.
okay, excuse me, Omar. Hello, Lee. Lee, you're there, right?
Okay. Yes, I love.
I'll talk to you in a bit. Lee, are you there? Lee's the translator for China. How you doing, Lee?
Yeah, very good. How are you?
Okay, I can't see you. I guess it doesn't matter if you don't have a picture or camera. It doesn't matter. So you're all set, right? Lee, you're all set,
Yeah.
right?
Yeah.
Okay. Yeah, you've done this before. So.
Yeah. If you can send me the YouTube link, is much better.
Oh, okay. I'll do that right now.
Okay. Thank you.
Yep. Okay, I'm going to send it through the chat. Okay, Lee. Where are you on the chat, Lee?
You can send me the email.
Yeah. Oh, email? I don't know if I have your address there. Do I have your,
Uh,
or I can send it to
Johannes?
Ahmad's WhatsApp.
yeah, sure.
Yeah, let me do that. Let me get to, I should be in there anyways. It's a great accessory program.
Ah, hey, Paulo, I can see you.
Good evening, everybody.
Good evening, Professor.
Greetings from Brazil.
All right.
Good morning to all at Syria.
Hi, Lee.
Hello.
Older man.
Okay. I'll have it to you in a second, Lee.
Okay, no problem.
Boom, 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 boom. I have to start my WhatsApp. It's not booting up as usual. Okay, just give me a second. Okay. I'm getting it, Lee. I haven't forgot you. Okay, here we go.
Okay, thank you.
Yeah, there you go.
Hey, John.
Okay, there you go, Ahmad. You got it, right? Yes, yes, Dr. Krish.
How come the name Ahmad Aboud is under my picture?
It's under what?
Under my picture.
Oh, okay, I don't know.
Is it because I logged on using his connection?
I don't know what you're saying. I'm sorry, Dr. Krish.
No, when you look at my picture, it's Dr. Aboud's name.
Oh, okay. What you do is you can edit that. Someone help him, okay? Someone help Dr. Krish. You go into the edit.
Yeah.
Okay. Yeah, and then you can change any name, whatever you want.
I see. All right, well, Michael is on. I can see him. Hey, Michael.
Hello, Ali. How are you?
How are you? Good.
Good. I see the same thing with mine. I'm Ahmad Aboud.
Yeah.
You can be, how you doing, Dr. Lawton?
I'm good. How are you, John?
Good. You can be whoever you want to be tonight.
What do I do? Just click on that?
Yeah, you just, you know how to edit it, right?
Yeah, I see. There we go.
Okay, 2 minutes.
Hey, Mike, we can run that song, I Want to Be Like Mike.
Yeah, there's really not one for Ali, is there?
Yeah. Well, you can be the great one.
Well, I think after the Tiger Woods thing, being great could be a casualty here.
I know, you're right about that. Yeah, we better settle to our operating room. It's safer.
That's for sure.
Yeah.
You see that with Paulo showing you there? Ali the greatest.
Uh,
Uh,
I wonder what Paulo wants from me now.
Wow. This is
Yeah,
the most we,
he doesn't do that just for fun.
I see.
Good evening, Professor. Good evening,
Hey.
Professor Lawton.
okay, everybody, are you ready? Mike and Ellie, I'll just introduce you and off you go, okay?
Sounds good.
Okay, let me just get off the spotlight here. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good evening, this is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We have the pleasure of hosting a series of webcasts, Achieving Mastery in Aneurysm Microneurosurgery, with two gentlemen everyone knows, Mike Lawton and Ali Krisht. So I'll turn it right over to Ali, and he's going to run the show. Welcome, Ali.
Sounds good. Can I have my screen just to share it for a second?
Yeah, you click on the share screen at the bottom.
Okay.
Yeah. If you click on the share screen and another
Okay.
screen opens up. There you go. Okay,
That's it. Okay.
there you go.
Well, we're not going to spend much time. We better go to business because there's a lot to cover. And this is an idea which I thought about and I discussed with Michael, Dr. Lawton, from the spirit of his book, going over the 7 aneurysms that he described and nicely kind of simplified it in a more understandable way in his book. And the idea of these sessions is to put a focus again into microsurgery of aneurysms. A lot of people have been talking about how this is going to be obsolete and it's not going to be needed, and not realizing also that there's a lot of progress that's taking place in this field in parallel with the progress that's going on with the other modalities, endovascular and so on. And the important things is going back to focus on the patients is if we don't continue to improve our techniques and we relinquish the use of microsurgery, there will be a lot of patients who will suffer from the pendulum being swung all the way to one modality when there are aneurysms which are best treated with a simple microsurgical approach than a more complex other modality, endovascular or what have you. So we're hoping that this will be a good primer for a lot of people who will look back at microsurgery, hopefully in a different way. And I have no doubt myself, and I know Michael will give his opinion, but we share a lot of thoughts in this regard that the microsurgical cure that can be achieved in a large number of aneurysms is at the present time superior to any other modality. And we hope that we will relay this point in our discussions and lectures. You have the schedule. It will be every Thursday, and we will be skipping the last Thursday of March because of the Easter break, so that he and I can kind of spend more time with our families. And at this stage, I'll introduce Mike quickly. Obviously, Michael Lawton has already left a major impact on our specialty with his work and his ability to relay his thoughts in a simple way and very clear way. That always reflects the level of his performance. Usually, a teacher who can present things in a very simple way, it means he understood it at the deepest level. And I can say a lot of things about Michael, but a lot of you already have a very high opinion about him, and it's a pleasure to introduce him, and it's really a special thing for me to be a friend of him. Michael?
Thanks, Ali. Well, I want to spend as much of this time that we have here to talk about aneurysms and about the surgery that we do. But I do want to say this, this idea was Ali's. He approached me and asked me if I wanted to do this. And, I do feel like he and I are both very blessed in this world and in the roles that we've inherited. We have been given the opportunity to do a lot of these cases. We both realize that that's not always true for the younger generation, where these cases are harder to come by. And I think both of us feel a very strong sense of obligation to share the lessons that we've learned with anyone who wants to listen, but primarily the young generation who's hungry to learn and eager to take on these cases. So it's in that spirit that we're going to do this. One of the things that I've tried to do is make this really dense, to boil down a lot of hard lessons into basically an hour that he and I will split. And so with that, I just want to get to it. I think the title of this seminar series is about mastery, but really it's foolish to think about mastery when really what we should all be striving for is competency. And I think we have to focus on really making sure that we are pretty damn competent in doing these cases and doing them well. And mastery comes, but it's not in and of itself the goal. So I'm going to share my screen. Give me a second here. And you should be starting to see my title slide. Can you see my title slide?
Yes, perfect, perfect.
Okay. All right, so the first session is on posterior communicating artery aneurysms. And I think it's a great place to start because, for a lot of people, this is what they would call a beginner aneurysm. But it's certainly not the case. This is the view. This is some art from Mark Shornack here at Barrow. And this is kind of the lesion as you encounter it. And I think it's very easy to just sort of get entranced by the anatomy. But I think with many things in life, what you have to do is sort of transpose this augmented view of reality on top of it. And this is how I think that view needs to look. These are the numbered steps that I go through on almost every aneurysm, PCOM aneurysm that is, just marching my way down a series of steps in my mind to make sure that I've done this or handled this lesion properly. So just to take you through this really quickly, number one starts with the optic nerve, and it's because you can always find the optic nerve. It's probably the best landmark in this field, and it's particularly important when you're dealing with a swollen brain after a subarachnoid hemorrhage. You've got to have something that's easy to find and will immediately orient you. So cranial nerve 2 is that landmark. So that's why it's number one. Now, number two, I hardly ever use retractors anymore. This is a much older drawing, but the point is that you want to create some space, this triangular space in the carotid cistern between the optic nerve and the tentorium is all that you have to work in. And so the more you can get it to open, the better. So you want to try and peel back the frontal lobe, whether it's with a retractor or without. And so number 2 and number 3 are really about that peeling back of the frontal lobe. Number 3 is just a little bit of very proximal Sylvian-Fisher split to get the frontal lobe to separate from the temporal lobe and allow it to peel back. And if you're in a good way, you can get all the way back to the terminus here where the A1 and the M1 come into view. So that's the kind of point that you want to get that peel back. Once you've got that, then you really want to get on that top surface of the carotid artery, number 4, with the goal to start to not march towards the aneurysm, but march in the other direction to number 5. And that's where you go right into this corner here where the optic nerve runs into its canal here and the internal carotid artery and the optic nerve intersect. And that's going to give you the very most proximal point for control of this segment of the carotid, this ophthalmic segment here, needs to be controlled right in this corner, because any clip that needs to go in there is going to take up space. So you want it to be as far forward as you can. And sometimes it's not as open or as distal here as this drawing shows. The aneurysm can be right snugged into your space. So proximal control is that number 6. And then we move on. Here, just zooming in, number 7 is really identifying PCOM. You only get this little knuckle here where the artery originates and then curls behind, out of your view, behind the communicating segment. And so what you're looking for is that knuckle, this little depression here in between, and the very earliest part of that proximal neck. Now, sometimes you can't really find PCOM and you can't even find the knuckle. So one of the ways to do it is to go over here, go into your carotid optic triangle here and look for PCOM on the other side. It's very safe in here because the aneurysm projects posteriorly and inferiorly. So if you go into this space, you can find PCOM, and it always follows in a straight line. These arteries aren't smart. They don't take crazy turns. So you can just draw a line once you line it up and extend it over, and that will help you find this knuckle. Now on the other side, you've got to find this little plane here, this little cleavage between the distal neck and the anterocoroidal, because the anterocoroidal is so vitally important. So that little separation is critical. And then before you go thinking about putting a clip on, you want to look at where the dome is intersecting the tentorium, because as you manipulate the aneurysm, if it's adherent here, you're going to have these pulls and tugs on the dome. And if that's a ruptured aneurysm, you could very easily re-rupture it. So you want to look at that, see if there's anything that you can release and make it a little safer for you to put your clip on. Putting the clip on should be a no-brainer at that point. If you've done all 10 of those steps nice and thoroughly, then applying this clip should be the easiest part of the case. And you found your knuckle here where that first blade goes. You've separated this choroidal off of the back here, so you know where the back blade goes. And it's just a nice controlled release with good visualization. Now, a couple anatomical points. You can see the classic anatomy here in the upper left, but you know, the artery parallels the course of the third nerve, so the third nerve can help you find things that you're looking for. This illustration over here is just to show you that, you know, you are going to see some fetal PCAs from time to time. Those are particularly important because, as we all know, the P1 over here is hypoplastic with a fetal PCA, and you've got to preserve that to keep flow to the PCA territory. Over here, this illustration just shows you the infundibular origin of PCOM. You'll see that frequently, usually not with aneurysms, but sometimes aneurysms can form at the top of the funnel. Here's how these project. They can project supratentorially on both sides of the tent or infratentorially. Most of them are these infratentorial projections, but these ones here, these are the ones where you've got those adhesions that you've got to be careful of. And these supratentorial ones, they're pretty rare with PCOMs. You're more often going to see that with an anterocoroidal aneurysm. It's a little further distal. But think carefully about how the dome is projecting. And then finally, a point about the anterocoroidal. The choroidal is where the morbidity comes from. You know, it's a poorly named artery because when you think of its name and the reference to the choroid plexus, you think that it's a harmless vessel, but it's so critically important because it's supplied to the optic apparatus in the internal capsule. So you've got to really pay a lot of attention to that and treat it like gold. So I'm going to run you through some cases, and these are just short video vignettes just to show some of these points that hopefully I've made. This you'll also see a lot of my residents and fellows operating because you know, PCOMs are relatively simple, and this is where they cut their teeth. So this is the anatomy that we've been talking about. You can see the projection. This is my fellow looking for PCOM and not seeing it. And as you look in here, what you're seeing here is this artery, but that's on the backside of the aneurysm. So we know that can't be PCOM, that's going to be choroidal, and the PCOM is going to be over here, and you still really don't see it. This is a case where you don't see that knuckle that I was talking about. But I'm going to show you in just a second the optic carotid window here, right here, and you can see PCOM in that other window. So let me just take you back to that. So there it is right there. You see how you didn't get much of a knuckle on that one. You only got a view of it through that optic carotid window, but you can see how it all lines up. You can go back and forth there. You see, you draw that line. Once you get a sense of its course, takes you right to where that proximal clip blade was. And so it tells you that everything lines up nicely. And here's just an overview showing a nice clipping. I usually use a straight clip, like a 7, or for bigger aneurysms, a 9. But that's really the go-to clip for this. It's just a simple single clip. So that's our appetizer. A basic case. You can see a good angiographic result, and you know, a good case to start with. Here is another case, another fairly simple one. You can see it's got classic anatomy. You saw that bend in the carotid. Here, let me go back. You can see on the CT angiogram that right angle bend of the supraclinoid carotid, where the ophthalmic segment ends and the communicating segment begins. It's often one of those Lawton rule situations that lead to this formation of the aneurysm there. And now going into the microscopic view, you see the aneurysm there. Here's our anterocoroidal artery. As we look behind it, you can see a P1 segment kind of protruding. Here's that little knuckle of the PCOM there. This was my resident applying the clip, and as I was inspecting his work, what I noticed was that there is still pulsation in the aneurysm, which told me that that clip was not fully across. And so you see here, I'm coming in and doing a clip readjustment to get the blades across. And if we go back and just look at the that initial clip application, what you see is that you really don't have a good view all the way across the blade. You can see the knuckle there in the upper portion of that proximal blade, but you don't get a good view of the tip of the blades and how it lays across. And so it's no wonder that that aneurysm still had some work to do. And that technique of palpating the aneurysm and feeling for a pulsation is really an important thing, because it'll tell you whether there's some life left to that aneurysm. So here's just a clip readjustment. And for validation, you can either use IC green or you can incise the aneurysm, which is what I'm doing here. I do like to take all tension on the nerve off. And you see there's a little dog ear. Those dog ears are very easy to deal with the little mini clip at the end. You can see a little intersecting curved clip. And once again, PCOM, you can see its perforators. Those anterior thalamoperforates are right there, coming off of the aneurysm. And it's a really important thing to take care of those. And also right here, you see the anterocoroidal, that little knob of the choroidal coming off right there, which we can validate as being open on the IC green. All right, so these are simple cases. We're going to keep graduating a little bit. This is, once again, a resident case, subarachnoid hemorrhage. You can see they're just opening the lamina here, going into the optic carotid triangle. You can see the blood around the dome. As we dissect, you see very nicely, here's our choroidal. You see how it lays over the back end. Here's that little separation that we talked about between choroidal and the distal neck here. So by pulling choroidal medially, we can get around. Now here's the proximal neck. This is that space. You can see it's very tight here on this short ophthalmic segment. And let me go back. As we go back here, you're going to see the knuckle of the PCOM for just a second. There's the proximal neck here. As I pull back, there's just a little view of the knuckle hiding in that corner. So now we can go on with the blade. But this is my resident clipping, and you can see, once again, poor visualization of the tips. You've got to be able to see all the way down the clip blade. So when I come in and inspect, you see that the blade here is not fully across. Let me go back and re-show you that. You see the tip of the blade there. It's in the fundus of the aneurysm, not fully across. And so that's what happens when you don't have that full 100% view across the clip blade. The alignment was good, but the distance was not fully across. And so I'm stepping in here and reapplying this clip, deepening the blade, and you'll see here that as I puncture the aneurysm and free the nerve, what I find here is that I haven't done a good job of preserving PCOM. The PCOM is actually going laterally instead of medially, but since I've already opened the aneurysm, I've got to first close it, and then I can have the luxury of adjusting that initial clip by sliding it back, releasing PCOM, and getting things reopened. Now here you can see PCOM with good patency there. Another case, this is a subarachnoid case. You can see a fairly swollen brain, and as we look at that angiogram, let me go back to that. As we look back at this angiogram, you almost don't see an aneurysm. You see a little bit of haziness right at the origin of the PCOM on that image to the left. And on the image to the right, you can see a little shadow there. And what I'm going to show you here is that that represents a thrombotic or thrombosed sac. So here we are just opening lamina to create some space. And this maneuver I wanted to show you here, this is incising the falciform ligament. The optic nerve is here, falciform ligament is incised, and you can see it gives us an extra 2 millimeters on that ophthalmic segment to get our proximal control pushed a little bit further forward. So now as we come on the aneurysm, you can see that there's thrombus here in the dome. And that thrombus in the dome is why we were seeing such an abnormal angiographic appearance. And let me go back here and just show you, here's that little knuckle right in that little space there. The knuckle is right there. That's enough for me to line up that blade, proximal blade. The distal blade is easy in this case. And now we can get that clip across. So here, once again, going into that carotid optic triangle to show or validate the medial course of PCOM. And then here, this is that thrombotic dome filled with clot. That's the reason it wasn't filling on the angiogram. And now as we peel that clot away, now you can see this aneurysm is quite a bit bigger than it appeared angiographically, but its thrombus internally was basically hiding it. All right, next case. This is a case where the proximal exposure on the aneurysm was very tight. When the clinoid is big and doesn't give you a lot of room for proximal control or proximal dissection, then what you can do is what I call a limited clinoidectomy. You're essentially just removing the tip of the clinoid to gain this additional space right in here. You can see this is where you need to be to dissect this aneurysm. And so by taking out the clinoid, that really is what opens up the space for this window. So it's not a full clinoidectomy. We don't need a ring dissection, but what we need is enough space here to open up this really tight window when the clinoid is so close to the aneurysm neck. As a rule of thumb, if you see that distance between the ring and the clinoid tip, if it's 4 millimeters, then you have to have a high index of suspicion for needing this clinoidectomy. So here we're just validating with IC green the PCOM patency, the choroidal patency. Here's the knob of the choroidal. PCOM is here, and everything looks good on that. And just to kind of fix in your mind here, this is the final clipping. If we go back to our initial views of this aneurysm, you see how this clinoid was so tight. Oops. Clinoid was so tight in there between the optic nerve, the proximal neck, and the carotid. And that clinoidectomy really made the difference. All right, here's the next case. This is an example of a thrombotic aneurysm. And for this one, you can see how thrombectomy and decompressing the aneurysm really helps to facilitate clipping. So here's just a Sylvian Fisher split. We'll accelerate through this, opening lamina terminalis to relax the brain. And this is another one where the clinoidectomy opened up this triangle. So here you can see this triangle of space was widened by the clinoidectomy. So for this, you can see this is all aneurysm here, and it's mostly thrombotic. So it takes some work to going to take some work to thrombectomize this and make this soft. So these are the clips going on. You can see an incision into the dome of the aneurysm. We can do a thrombectomy down until we reach some lumen here. And there's a little bit of back bleeding from PCOM. But once we've got that neck softened, we can go on with a fenestrated clip, come off with our trapping clips, and now we can create this tandem clip construct that essentially closes off the neck. And this aneurysm, you can see, just went on all the way down to the prepontine cistern. And here at the end, it's been widely open. Here's a view in that carotid optic triangle where PCOM is over here. And you can see we do need to do a little bit of clip readjusting here to free the PCOM now that we have more space and a better view. So I go on with another fenestrated clip. It's going to allow me to readjust this first clip. This is a closing clip, which is part of this tandem clip reconstruction. And now you can see we've got the PCOM released, and we've got a good reconstruction. There's our icy green showing patency, and you can see here, nice reconstruction of the carotid. So I'm getting short on time, so I think I'll skip this case. This is a ruptured anterocoroidal angry brain. But I think I wanted to spend a little time, the last 5 minutes or so here, talking about this, trouble during clipping. And, you know, PCOMs are supposed to be simple and easy, but when I think about the intraop aneurysm ruptures that I've dealt with, many of them come during PCOMs for whatever reason. Maybe it's because we're a little bit more liberal in letting our residents do these cases than other aneurysms, but for whatever reason, we see it. And so I want to show you a couple of those cases. This is a chief resident operating, and you can see that just by pushing on the dome of the aneurysm, this aneurysm starts to bleed. And these are really important experiences for the residents. I think, you know, if you really want to get good at, as an aneurysm surgeon, you've got to go through some intraoperative ruptures to gain confidence and feel as though you can work your way through trouble. So here he is. He does the right things here. He put a cottonoid down to tamponade the bleeding site, and he put a temporary clip on, but it was a poorly placed temporary clip. And you can see here that it's really not doing its job in occluding the carotid. So he has to abort that. He has to go back in there and try and get that temporary clip in. He's changed to a large bore sucker, which I'm not sure he needed, because I think the standard microsurgical suction can usually keep up with this. But this is when I stepped in because we weren't making progress. And so here's just showing the steps. You've got to get that sucker right over the spot where the bleeding is. And once you do that, you can keep the field dry. And here's the problem. The proximal control, those early steps that I walked you through, were not done thoroughly enough. And so my first maneuver was to get more proximal on that ophthalmic segment, get that temporary clip further forward. And now I've got control. We've got the bleeding under control. You can see the neck. The tear in the aneurysm is back on this corner here. And this allows me to see my 2 points of clip application. One here in that proximal spot, the other in the back here. Now what you'll see, because of the tear back there, it's not fully addressed. This is choroidal. I wanted to make sure I had that taken care of. But now you can see that we still have a little bit of work to do. Or maybe not. Maybe we got that. Yeah, we got that with that one clip. And so it was just a matter here of addressing these issues: a limited exposure in the surgical field, an inadequate proximal control. He was too distal on the carotid, but he responded well. He got the suction in. He had good tamponading with the cottonoid, but in general, a good response to the problem. Now here's another case. This is again a PCOM, a right PCOM. You can see the carotid, and boom, here's a failure to recognize the dome for what it is. And the tips of those scissors went right in. And so, again, good positioning of the suction, drawing the field. He could have used a cottonoid, but didn't actually need it. But look what's happening here. He's putting his temporary clip in, and it's distal to the neck. The neck is here, so he doesn't have a good sense of where that clip needs to go. And so he gets booted from the chair, and I go in first with that cottonoid to control. And once again, it's all about getting further proximally on that carotid. Here's that little space between the edge of the tentorium where it joins the clinoid and where the neck of the aneurysm is. And here, this first clip goes in there. And what I think is a good clip placement, you can see there's still bleeding. And that just tells me that the blade isn't in the right space. I haven't gathered in the neck properly, but I can use that first clip. Oops. Sorry. I can use that first clip here as a template. So even though we still have a hole in this aneurysm, I'm going to leave that first clip where it is. I'm going to apply my next clip right on top of it because I can see here, this is the tissue that I need to gather in. So this back blade needs to go in this space right here. The front blade was fine. And that first clip is actually going to help me. And you can see how this better clip application takes care of the reconstruction here. So for this rupture, once again, limited exposure, failure to recognize the aneurysm, which led to the perforation, and the proximal control. You know, when things got rough, you didn't know exactly where you needed to go with that temporary clip. So really have to have those things clear in mind as you do this. And third case is this one here. Again, another chief resident operating. This is one of those examples of where the aneurysm is really adherent to the tent. You can see it's the edge of the tent is here, and the aneurysm is stuck. And this temporary clip was a good idea to try and soften the aneurysm, but it's way too close to the aneurysm. It's really difficult to get enough space between that clip and the proximal neck to find that knuckle of the PCOM and expose the anatomy that you need. So here is some bleeding as he works to try and do his final dissection. You can see that dome tears. He was too close to the dome. And this quickly escalates. So I've stepped in here. Again, the first steps are tamponade. My first maneuver was to get that proximal clip further anterior on the carotid, really wedge it into that space just as the carotid comes past the distal dural ring. And you can see with that well-placed clip, now the bleeding is much more manageable. Now I can start looking for my anatomy. There's the PCOM in the back. Here's that adhesion to the tentorium. And by opening up that adhesion, I can start to get into this space here to look for the PCOM origin. So now the aneurysm is mobile. I can work that space now. I can find my PCOM in that interval there. And now I know exactly where that proximal blade goes. You can see how the posterior clinoid is an obstacle in the back, but I can see what I need to see. And I created that window by separating the temporary clip. So now the aneurysm is nicely closed. You can see good flow in the carotid, and we've got that dealt with. So for this case, demonstrates poor placement of the temporary clip. It was too close to the neck, insufficient dissection of the aneurysm adhesion, and too much dissection at the dome. We should really focus right at the neck where the work needs to be done. So I wanted to show you those because, you know, it's easy to talk about the technique, but in the best of circumstances, but you've got to have a grasp of this anatomy and these lesions so that when you get into these more difficult situations, you can deal with it. It's almost as if you don't even need to see the anatomy when it's so clear in your mind. You just have to work through the bleeding. And I think these quotes are great. You know, uncontrolled bleeding is the thing above all others that unnerves the surgeon in the operating room. So learning how to deal with that and learning how to control the bleeding is so critical in all of our development. These are just some numbers from intraoperative rupture experiences. You can see that if you look at these groups, which are chronological, 1 being early in my career, 3 being late in my career, you can see that the ruptures, the timing of the ruptures changed from many of these occurring during pre-dissection to most of these occurring during dissection. And that's really what you want. You want, you don't want to put the clip on before it's ready, which is this pre-dissection phase. And you really want to almost over-dissect the aneurysm. You want to really make sure that everything is ready so that when the clip gets applied, it's straightforward. And the clamp times go down as years go by. I think that's a response to experience, and the outcomes improve. So I think you know, the lesson is that you just have to go through a bunch of these. They're painful and unnerving, but I think as you do it, you get better. And this is my last case. I'll just show you this to show one of my own misadventures here. This is a PCOM. I clipped it. Everything went fine. And so here I'm puncturing the aneurysm. And you know, we do a lot of research. I was harvesting this dome for our studies. And so the dome comes out, and we've got the transected aneurysm. And just cleaning up here, I was mopping up and trying to get some blood out of the deeper cisterns here. So here's the PCOM here, third nerve, posterior clinoid up here. And you'll see that my traction on the internal carotid artery here ended up tearing the wall right there. So now we've got a little tear in the internal carotid artery. It's not the aneurysm. The aneurysm is secure, but we've got a tear in the wall. And I think, you know, first is just surveying things. I tried to tamponade here with some Neunit, but you can see that rather than the Neunit slowing things down, this tear seemed to be getting worse as time goes by. So what do you do in this situation? Well, you gotta do a clip wrap, or you've got to do a definitive repair of this tear in the artery. So here you can see it's essentially just an open hole in the artery. There's no clip configuration that's going to take care of that. So you can grab a piece of muslin or a piece of Gore-Tex off the shelf, you cut it into a thin strip, and you encircle the spot where the tear is. And you essentially make a wrap, or a little, what I call a little taco. And you can see how we've left, I've left the fibrillar on the spot where the rupture is. I've created my sling. And then with just a little stack of these clips, we can apply some pressure on that sling to make it nice and snug. And you can see how that completely controls our tear. So it's a nice way out of a tough situation, and just wanted to throw that in there just so that you keep that in the back of your mind. So I'm going to wrap up here. You know, I think with PCOMs and intraoperative ruptures in particular, these are the technical responses. These almost need to be reflexic without thinking. Suction, tamponade, proximal control, distal control if necessary, cerebral protection, and then working quickly and efficiently. You've got to have a mental response, which is to have envisioned these problems, to have already thought in your mind's eye what you're going to do, and be ready to think through the problem. Sometimes you don't know where the bleeding is coming from, so you have to keep working and thinking at the same time. And then, you know, there's this visceral response that I know most, if not all of us, have gone through, this rush of emotions, and you've got to maintain your calm and clarity through that all. It gets better over time. You do develop a certain numbness and a certain confidence that you're going to get through this, but really it's just a matter of getting through these experiences. I showed a lot of resident cases just because these are like gold for them. It only happens once or twice a year. And, you know, if you can get one of those experiences and work your way through it, you really grow as a surgeon. So I'll finish with this. This saying that it's just a PCOM is a dangerous saying. These are some data that show that over time, the list of complexities that go along with PCOMs only gets bigger and more. They get more frequent as we have endovascular therapies cherry picking our cases, and so these have become quite challenging in their complexity. So these are my concluding thoughts. I think we've covered all these, so I think I'm just going to stop and turn this over to Ali.
Thank you, Mike. This was very kind of clear, instructive, and great examples of how to think through problems. Can you see my screen?
Yes.
Okay. So, you know, I've read Michael's book, and I went over his thoughts as he presented them and tried my best not to overlap, because he very nicely showed the steps. And it's important not to pass over the steps he mentioned in a structural way, how to follow them, because these are the basics of how to stay safe in approaching these lesions. So I'll start by mentioning one thing. When approaching microsurgery, this is a process that evolves to a moment, and that eventually becomes part of your character. And that's very, very important to know. This is not only a technique. You have to dedicate yourself to what you're doing and put your heart in it. This is why I'm very lucky to have so many great teachers, all under the umbrella of Professor Yazergil's technique. And if you look at his surgery and the way he improved aneurysm surgery more than 40 years ago now, you can see all these basic stuff in his book, and clearly mentioned all the aspects of how to successfully treat these challenging cases sometimes. Now, as Michael said, you know, mastery is not something we achieve. Mastery is something we aspire to. Really, to be a master is to become a master student. That's the best thing you can do. But it all starts with the basics. And as he alluded to, you have to know the anatomy of, number one, the normal, and number two, the abnormal anatomy, the anatomy of the pathology. That's why, as he mentioned late, that you're able to see with your brain where your clip is going to go, and that's how you can kind of get yourself out of trouble. Now, when is surgery superior option is something important to know, because in the present environment, there's a lot of competition with other options, and they will look, and a lot of times they are better, but surgery is best used and indicated, as Professor De Oliveira, who has recently passed away. He was one of my vascular mentors. He puts it nicely: when done at a superior level. And in all aspects of surgery, this is true. When you remove a convexity meningioma, which is easy for you, it becomes indicated to be operated on if it's symptomatic. And when you remove a grade 1 or 2 AVM, when you feel you can easily do it, it becomes the most superior option in a way. And with aneurysms, it's the same. It's achieving that level of knowledge and comfort and confidence. Like Michael said, confidence is going to come from knowledge and from experience. And that's what makes things that look very complex much easier. Then your performance is going to improve well. And this is a picture of Professor Evandro in the lab as recently as 3 years ago when he was here. And you can tell that our knowledge will always improve if you spend more time in the lab. Now, Michael mentioned very nicely and clearly the steps. I will just, I made sure, like I said, not to overlap, and I'll just throw some points that come to mind. Think of the arachnoid like a continuous band, and if you retract one location, it's transmitted to a far distant location. And that's why dissecting the arachnoid is going to spare you from a lot of cases of rupture. So on one hand, you release the spinal fluid so that the brain is more relaxed, and you disconnect the brain lobes so you have more space, and you avoid premature rupture, because this is the best way is to keep the aneurysm asleep. And it's like you're sneaking into a house and you don't want the people who are asleep to wake up. And that's the best way to approach it. And this will eventually lead you to very minimal need for retraction, which is what causes the problem. Now, think of it in a different way. Aneurysm surgery should not be looked at as brain surgery. It is subarachnoid surgery, and the whole surgery should stay in the subarachnoid space. It is very few times that we end up doing brain surgery, like removing a gyrus rectus, a little bit of the insula or cortex, just to look around the aneurysm. But you have to tailor your approach to navigate the subarachnoid space successfully to get as much exposure as possible. Now, Professor Yazagil and I, we used to discuss what would be a good term to describe how to approach these aneurysms. And like Michael mentioned in his last graph, how his experience with time decreased the incidence of rupture and make his surgery much more safer. And this is one way to do it, is really to go as far as possible from the aneurysm to get control before you come and tackle the aneurysm. And that's what we coined the term circumlinear microdissection approach. And what that means in PCOM, and in addition to the steps he mentioned, you have to find a way to very early, before you see the aneurysm, get proximal control, as well as a distal control, which in the way I like to do it is to go to A1. And the reason is when you put your clips on these points, then you are away from where the aneurysm neck, and like Michael mentioned, a lot of times he showed his residents, when they're putting the clip, you can't see well around the corner, especially where the knuckle is. And then if you open part of the proximal sylvian fissure, then you have good visualization of the anterior choroidal with all these steps, just like he mentioned them, but have in mind that you don't want to tackle the aneurysm before you have a view like this. Then your clip will have eyes and you can see better. The next step, and he mentioned some of them, is you have to feel like you can tame the aneurysm. You cannot be scared from an aneurysm. The aneurysm should be scared from you. You should be able to know how to use coagulation, shrink the aneurysm to better visualize around it. You can stop the bleeding site. My goal is always to convert the case from a rupture to a non-ruptured situation. And then you can take your time reconstructing exactly what you need to do. Now, I have a low threshold to use temporary clips. I use what I call a pilot clip, which is the initial permanent clip, not necessarily the perfect clip. I don't try to get the perfect clip the first time. I want to secure the aneurysm the first time. If it turns out the perfect clip, that sounds good. And then you remodel the aneurysm, simplify it, and then finally clip it, because you don't want to leave anything behind. Because the big advantage of microsurgery is you can do a perfect curable approach to it. So as in the title here, clipping is a process. It is not one step. So sometimes I may spend more time on clipping an aneurysm than getting to it. Now, PCOM they really rupture in a nasty way. And if you see all these cases, they have a lot of difficult brain to deal with. So over time, I've realized that the brain can be a problem. And you've seen some of the videos that Michael showed. Now, I spend a lot of time in and around the cavernous sinus region. And a lot of times when I'm operating, especially in this area, I realize that I can see really very well this corner if I get this region fully exposed. And my technique has evolved to where, like in this case, you can see how the anterior clinoid, as Michael mentioned, in some cases, could be hiding the proximal part of the neck. So this has been addressed. This is a picture from Yazergil's book. He showed the points of exposing the proximal knuckle, so you can see it well in some cases, because the anatomy is very different. Some carotids are short, some are long. There's all sorts of variation. But I realized that when we use the pterional approach, I used to get this window, but now I widened it to where I use a more pretemporal space that I can see all this view, and I have much less blind spots. And over time, I evolved to be able to see this, and I liked it over time, and especially that with PCOM, a lot of times when you clip, there is a blind spot in this region where we left this part. And I have seen, a couple of cases that I have reoperated on, I wasn't happy with, and I decided I need to see more. And since then, I haven't seen any case that comes with a residual, because we really go out of our way to see them. So the approach now, I aggressively remove the sphenoid bone, but at the same time, I expose the pretemporal space. And the whole idea is to stay under the brain, so I don't deal with a swollen, difficult to deal brain. And at the same time, in this way, you have a much larger space in the pretemporal area. So there's a little peeling, just anterior part down to V2, and remove the clinoid. And you'll see in a second with this approach, removing the clinoid, exposing sometimes the proximal carotid in the clinoidal segment, because especially in older patients, sometimes the supraclinoid segment is calcified. You can't put a clip on it. If you go more proximal, you'll be easier to find it. Now, over time, I started cutting much less dura. I opened just over the optic nerve and over the subtemporal region. And the view you get is, in the majority of cases, if you create this pretemporal space, you're able to see the whole anatomy, because all what you need is the proximal and distal control and enough space to maneuver around it. So the next thing is to take this clinoidal dura, which will give you a wide exposure to the proximal part of the carotid, so you can put your clip safely. And then once we open the proximal fissure, then you have a view. And the next thing is to remove this dura. And in this case, removing it is exposing the proximal part here. And then the view that you will get to see the knuckle and where it goes further becomes a much more clear anatomically. So here's the part which we open the proximal fissure. You're able to see the region of the anterior choroidal. So we have A1 exposed, and we have the proximal carotid, a big span of it. You can go proximal, or if it is short, or if it is long, then you can go distal to the ring. And in this case, this is the exposure you get in overall majority of cases. And now you can see how much space I have. This is A1, this is the proximal carotid. And the clip, I like to put the clip on the A1 because it does not obstruct the view. Now, if you look here, you can see how much space you get. And when you apply the clip, the blind spots are minimized. So now I have full visualization of the distal part of the clip on this side, and you can see the knuckle and the anterior choroidal. There's like an aneurysmal pouch around it. And this is the next clip I apply to it. And then you can, this is because it was a little bit full, and then we dissect the aneurysm. And as Michael said, I always like to decompress the third nerve, especially when patients have a compression, when this patient presented with a third nerve palsy in a way. So at this stage, then, to visualize better, because like I said, there is always a small residual on the underbelly. So I want to make sure that this is not the case. So now we are dissecting the aneurysm. away from the attachment to the third nerve. And in this case, we made sure that it is collapsed. So now I have an unruptured aneurysm, and I will dissect it because I'm not happy the first clip I applied was able to give me full visualization of the anatomy. And that was what I call pilot clip. This was coined from Professor Yazagil. Now I'm compressing this because it's a little sclerotic, so I can put a clip on it and coagulating it. And still the challenge for me is there is a small residual on this side attached at the crotch with the PCOM. So this clip closed the bleeding spot. So now I have an unruptured small aneurysm, and I can see the crotch well, and I can see the takeoff of PCOM. So I will put my perfect clip in a way, and then I have full visualization of the anatomy. You can see the PCOM behind it. And there is a small clip, small blister that will put a clip on it. And then the advantage we got here is, you don't see much of the brain. And at the same time, when a case like this is dealt with in a ruptured case, you don't have a problem. This is a coiled aneurysm, a patient who presented with a progressive third nerve palsy. The aneurysm is growing. So we do the same thing. We open like a triangular space. And again, the real advantage is going pretemporal and at the same time getting as much proximal and distal control. Just like Michael mentioned, you go out of your way to stay away from the aneurysm to get a full approach. So this is the A1 segment that we are getting proximal control. And then you can see the area of the aneurysm. It's a very long aneurysm, and I have full visualization. In this case, I can see well. I didn't put the temporary clips, and I'll put my first clip, which is the pilot clip, and then I'll decide how things look, because I still need to decompress the coils if possible. And the next thing is to dissect the dome, and you have to do it very carefully here because the coils are digging inside the third nerve. So this is the aneurysm collapsed and mobilized. You can see the coils here in this corner. Unfortunately, I couldn't pull them out. I would have injured the third nerve more. So I cut the aneurysm away from the coils and then mobilize it. And then next is I will put my perfect clip. I will evaluate if this is good enough. If not, you see, I didn't see the PCOM well at this point. So I need to get a more perfect clip. And in this case, I'm going to clip the dome and take the first clip out. And this will make this like an unruptured small aneurysm. So, but not to take chances. What if it bleeds? Because I don't know if I caught the dome well. So now I'll put my temporary clips and take that first clip so I can visualize the neck and see where PCOM exactly is, because I'm not sure if I caught the PCOM. So the next thing we'll do is I will find PCOM, and now you can see it, I'm lifting it up. Now I know where my next clip is gonna go to include the neck area. And that's where the clip will, and this will be my kind of, in my mind, the perfect clip in a way. So I took the coils out and converted this from a large aneurysm to a small unruptured aneurysm, and then we'll take the clips off. Again, you can see the wide view achieved, even though I didn't open the dura much. It's a small opening in the dura. I don't know if you can see. You see, that's the dural opening. So we're staying under the brain. This is a ruptured aneurysm. This case has like was shown, 2 domes, and this is a clot in the temporal lobe. So that's a full brain, but still, in this case, they didn't have much subarachnoid blood. So the first thing I do is go to the lamina terminalis and open it. And this is over the optic nerve, and this is A1. So I have my proximal control already at the clinodal segment, and I got my distal control. So when I'm opening now, I'm secure. I already got the full control of the surgery. And now I'll open the proximal sylvium fissure. And then now I have A1, optic nerve, and now I'll clean the clinodal dura in order to get a clip which is more proximal here. And this is the clip on the clinoidal carotid, the clip on A1. And notice that the view for my aneurysm now is free. This is, you can see this, sorry. So this is again the clip on the clinodal segment, clip on the A1. And again, I like the A1 because it creates a space for me to put my clip. And in this case, if it ruptures, it's gonna ooze, it's not gonna have a massive bleed. So I rarely deal with a premature rupture. As Michael said, premature rupture a lot of times is generated by the surgeon if you don't have all the knowledge about the anatomy and where you need to be at any particular moment. So now the next step is I'm going to dissect the aneurysm because I want to find out, if I clipped it well. So here there is a hematoma in the temporal lobe. I don't have much space, so I'm opening the clot and removing it so I can gain more space. And now cutting the aneurysm, and you can see PCOM now behind it. And now we are dissecting the ruptured pseudoaneurysm, removing it. And then the next thing is to see, and if you remember, there was two pieces or two lobes of this aneurysm, but now you can see very well the aneurysm, it's all well clipped. And I don't know why sometimes we add clips. In this case, it was enough probably. But you can see the clips and there's a cottonoid behind it and the tips are visualized. And notice how much space, again, we created. And this is an acute rupture with a big hematoma. Again, the space was created all on the outside. This is another unruptured PCOM on the left side, just to give a different orientation. And we're opening in the same fashion. And the window is more anterior in a way. And this is the view you get. You see, to me, the removal of the anterior clinoid has been so advantageous that now this is a clip that's going on the proximal carotid, another clip on the anterior communicant A1. And now the next thing is to look for the anterior choroidal. And you can see the takeoff, that knuckle that Michael was mentioning here. And my clip has eyes now. I can put my clip without any blind spots. So, and then the rest now is, like I said, I work on the aneurysm. I cut it, look around, find out where it is. Now, in this case, the underbelly that I talked about, you will see it in a second, which is what you have to be able to see. And I put the temporary clips now, again, because I am afraid to have left the residual. You see, I take the aneurysm, look around. You see this underbelly was not included in the aneurysm clip. So now I will put a curved clip so I can have a perfect view. And then we will take the clips out. And then I know I perfectly clipped the aneurysm. And that's a reinforce it with another smaller clip. So this is a ruptured case, again, an acute case. This has, a more difficult brain in a way, but Again, the exposure is similar. Get proximal control, and that's the falciform ligament being removed. And then I don't have to deal with the swelling in the brain in a way. And this is the proximal clip on the carotid. In this case, it's a long, nice carotid. I don't have to use the clinodal segment. And in this case, Michael mentioned a case where the PCOM was swinging medially, and that was the case here. So I put a clip on PCOM medial to the carotid. This is the left side. And then another clip on the carotid itself. And then a third clip on the A1. So I have 3 clips, but an unobstructed view of my aneurysm. And again, it's the space that is created in the mesial pretemporal and clinoidal area that allows me to be able to see very well and then put the clips and with full visualization. And then later dissect. Do not throw the clip and go home, because if there is something wrong, that's the best time to fix it. By the time you're in the recovery room, things are not as good. And that shows, again, relaxation. And I'm putting a curved clip. It has the same, like, small residual under it. So so this is one more case where the clinoid segment was really short, and I felt it's best to be ready to put a clip in the clinoidal segment because the supraclinoid was really short in this case. So again, the steps are similar. This is the view we get, and opening the proximal part of the fissure, and then getting down to where the aneurysm. This was a good-sized aneurysm, and the clinoid would have been covering this area. And again, inspecting the course of the PCOM, in this case, which is on the medial side, you can see some of the perforators coming here, and that's PCOM. And now you kind of map the anatomy well, and then you have full visualization in a 360 degrees. You can see the PCOM here coming down. So the next is to put the temporary clips in place. Oh, now in this case, obviously, let me just show you one thing. So this is the temporary clip on the clinoidal carotid. This is on the A1. And now you can see the anterior choroidal, and we open the proximal fissure, and you can see now the aneurysm, neck. And this is the knuckle, the takeoff of PCOM is up here. Again, look at the advantage with all this wide exposure, you're able to see the tips. Just like Michael said, it's an important point to thrive to see where your clip is going. If you apply the clip blindly, that's when things can go wrong, because you will leave aneurysm like he showed, his resident left part of the aneurysm. This is a very large PCOM, and then I'm putting another clip in order to get a good purchase of that small residual. You can see it here, you see that? Oops, I messed it up. But you can see it, and then now we look around, you can see the tips of the clip, and you can see the perforators coming from PCOM, and you have full visualization of it. So the theme is the same. I myself find it a very important that you do not get close to the aneurysm before you are fully secured, and you don't, I would go out of my way with the exposure. Exposure is key, And even though I feel like sometimes I can comfortably manage a rupture, but I don't myself want to see a rupture. This is an acute rupture case. Again, you can see the ability to see the A1 easily without retraction because I'm operating under the brain. And I'm trying the clip early on and then making sure that I am secure. I already secured part of my proximal. So by the time I open the dura, I have already established proximal control. So now this is a clip on the A1. This is on the clinoidal carotid in this case. And I'm checking the aneurysm to see that it is slowed down. And then I will dissect the proximal part. I can see the neck region. I'm looking for the anterior choroidal. And then the next thing is to put the first clip, which is the pilot clip. And the other advantage when you remove the anterior clinoid, you can see the course of the third nerve, which will help you direct your clip because you don't want your clip to be directed towards the third nerve. So that's an advantage you get. So now I'm checking the filling in the aneurysm because it's kind of not clear. I see no flow. And then taking the clips away and then going back to dissect the aneurysm, finding out the rupture site and cleaning it. That's the third nerve. You see the direction of my clip was away from it. And with time, like Michael mentioned, with experience, you know how to angle your clip so that you're avoiding all these structures. But to avoid them, you need to know the normal anatomy of these structures. So now, I'm sorry. Now you can see I'm coagulated the stump and I can see fully the aneurysm and this included, and then the PCOM is behind it. And if you notice, I didn't deal with a difficult brain. This was a difficult brain, a very tight brain, but the opening was small. And that's, if we're gonna do, you know, a treatment option that is superior to the other options, we have to do it to where nobody can argue with you that you are damaging the brain and that endovascular or other procedures are less injurious, because this is as less injurious as it can be. And there will be many examples, but I'll show this last and go to my conclusion. Again, the same theme, you get plenty of exposure without difficulty. So I'll end with this picture. You know, the eagle is always being picked on by ravens. And I look at eagles as, to us, it's our microneurosurgery. But the way the eagle overcomes the other modalities in this case is it goes higher. When it goes higher, the raven cannot breathe because there is not much oxygen. So in that case, the high level microsurgery will make other things disappear because the raven will leave the eagle. So if we can operate and elevate our surgery to a level where it cannot be competed with, it will always be the best option for many, many of the patients. Not to deny the advances and the benefits of endovascular treatment, but again, microsurgery is only limited when you don't use it, and it has no limit when you use it. Thank you. I'll stop here, and I think we can take few questions. Michael, what do you think? How is your time?
I've got an AVM case that I'm needing to go to soon, so we can do a limited number.
Okay.
That's okay.
Okay.
Let me stop sharing there here.
Okay, panel, we'll open for questions. There's a couple in the panel in the chat, Dr. Krisht and Dr. Lawton. How do you approach aneurysm neck tears after clip application?
Michael, you want to?
Well, yeah, I don't know that there's a simple answer to that. I think, you know, the tissue can tear in so many different ways. I think the answer is that you have to first control the bleeding, treat it like an intraoperative rupture, which means to get some temporary clips that isolate that segment, and then survey the damage. And I think with tears at the neck, one of the good tricks to remember is cotton. If you can get a little cotton on the rupture site and clip that into the reconstructed clip, then that has a way of tamponading a small tear. If it's a larger tear, like the one that I showed you in my case, you know, that clip wrapping technique can work very nicely. Sometimes, you know, you just have to dig into the bag of tricks, and it just depends on what you're dealt with. I think you just, it's why I said at the end, you go into these cases with contingencies in mind, so that when things happen, you're not stuck by having to think through it. You're just reacting and resorting to a plan that you already considered.
Okay, thank you. Question for Professor Lawton. If there's a large unruptured PCOM, where would you like to do the partial clinoidectomy? Would you do the procedure extra or intradurally?
Yeah, so I'm comfortable either way. Honestly, it makes no difference to me. I have always felt like I only want to do what's absolutely necessary. To me, the elegance is not in the technique, it's in the application of what you need. And if you can just apply what is needed, then it becomes more elegant. So to me, getting into dural and seeing the anatomy and what's needed is a great way to decide whether that clinoidectomy is necessary. And if it is, then most of the time I'm already intradural and I just take it out intradurally. In those cases where I'm absolutely convinced that I'm going to need to do a clinoidectomy just by the preoperative films, I might do that extradurally. But you know, honestly, it really doesn't matter. As long as you're comfortable with the technique and you're not doing it carelessly. I do think that sometimes when you do it extradurally, you don't always get to see what you want to see. It's not as important for a PCOM where the aneurysm isn't as intimate with the clinoid as, say, a paraclinoid aneurysm. But yeah, I mean, either way.
Okay, very good. Waleed Abbas, do you want to ask a question directly, or would you rather I ask it? I don't know if Waleed is there. Okay, he asks, oh, go ahead, Waleed, go ahead. Go ahead for the question. I'm sorry, Omar, go ahead.
Here, for the Chinese here, I cannot find any question, so go ahead. Thank you.
Okay, Omar, did you have a question?
Okay. Thank you, Professor Ali and all professors. I tell our professor, general surgery, Musa Barakat at Aibo State University, he tell us big surgeon to always to be the area of the surgeon is very obvious. Like Dr. Ali, to make a triangle to make obvious to the carotid artery and inside the first one carotid artery. And this is my idea about these things. The region of the operation area is very obvious. Big surgeon. Thank you for all. Thank you for Dr. Ali and Dr. all.
Okay, I hope you understand that. Michael or Ali, did you understand Omar's question?
If I understood that, you know, if you have big exposure, maybe for big surgery or something like that, that's, you know.
Dr. Ali, big exposure, big surgery, like Dr. Munza Barakat, general surgery, 1992, he tell us, make the area of the surgeon is very obvious for you. It's very good for results. This meaning.
Yes, I see. I understand. Yeah, and I agree.
Okay.
I think we both agree. You know, Michael and his technique and his mind. I have done the same for most of my cases in the past. I've done them exactly like what Michael has done, and I still do some like this. But over time, the advantage I got, and in my hands, the entire clinoid step takes few minutes extra. With experience, you feel like you can see it well. I found a big advantage, especially if you're operating and with my fellows partners, if they're doing these cases, their level of comfort is so high. They have temporary clips applied and they tackle the aneurysm with confidence, and the nervosity is gone. So that's the big plus with it. But with someone like Michael, you give him even a smaller window and challenge him. He has enough experience, like he said, he can see it with his brain and clip it. And I probably can do a lot of things if they get challenging. But I think the best operation in your hands is the one that you know best, and the one that gives you a high level of comfort and confidence, so that when you're dealing with a trouble, you don't flinch and you keep going. Going back, one comment I will add to the question about the rupture from the neck. The first thing you want to do, the first thing I think of if there is a rupture in the neck, is you need to understand it and not to make it worse. The first thing is you want to visualize, you want to know what happened. The first clue is to remember what was the last thing you did when this happened. Then you know what could have caused it. And the other thing is a rupture that is in the crotch is different from a rupture in the neck, because the crotch is the attachment of the carotid, of the artery to the aneurysm. That's a little bit more sticky. The rupture of the neck of the aneurysm, if this is what I find, I feel comfortable putting temporary clips and coagulating the aneurysm and shrinking it down. In that case, bipolar coagulation has really got me out of very dicey, difficult situations. But keep in mind that the worst enemy of a rupture is the surgeon's reaction. As Michael mentioned it, and I want to stress it, the worst outcome from a rupture is not the rupture, it's what the surgeon does. That's what decides the outcome. Rupture is not a big deal. If you are comfortable, what you do is you have your team to give you a bigger suction. If you have a big suction enough, you can suck the blood, there's no problem. You need to see what happened and make a good plan and don't rush. And that's what bails you out. That's more important than any steps you can do. And Michael mentioned it. You don't want to start throwing clips blindly or with kind of nervosity. Then you will make it situation. It could be very easy situation. You make it very difficult.
Omar is from Syria. Omar is from Syria. Okay, yes. Waleed, do you have your question? Are you ready, Waleed?
Not found any.
Oh, go ahead.
Oh, not to find any question here. So please go ahead. Thank you.
Okay. Okay, more comments or questions?
Okay, comment.
Okay.
Thank you, Dr. Ali. Thank you, Dr. Ali, very much. Very good lecture. I tell about if any rupture of aneurysm, we can get by temporary clips to make a plan how to do temporary clips to the carotid or the artery. Okay, this or especially or the proximal artery. to the aneurysm. They get time to take more for to thinking about what happened, to make a plan to deal with the aneurysm. Thank you very much, Dr. Ali, and to all.
Yeah, you're welcome.
Okay, a question from Wira Wong. Is it necessary for all cases to use double clip to secure aneurysm occlusion?
No, it's not. Sometimes the best clip is just a simple single clip.
Okay. In the case of, go ahead. In the case of PCOM fetal pattern, how does the surgical planning change?
What was the question again?
In case of PCOM fetal pattern, how does the surgical planning change? Does that make sense?
Did you understand the question, Michael?
Yeah. Does the presence of a fetal PCA change your plan? The answer is no. You know, the anatomy is the same. You will sometimes find some unusual origins of fetal PCOMs from the base of the aneurysm. So you have to study those a little bit carefully in advance. And I think it's just the same technique, but a little bit of an increased care in making sure that that artery is well reconstructed. Because if you have a complication with a PCOM, you can get away with a sacrificed PCOM. If you get a complication with a fetal PCA, you probably won't get away with a sacrificed fetal PCA. So you just have to be really careful to preserve it.
Yeah, I would add one thing with fetal PCOMs. You have to keep in mind that you're going to have a significant backflow. So the temporary clips that you normally apply may not be enough because of the backflow. And this is one negative. One positive is it's easy to identify when you're putting the clips. Sometimes it makes the application of the clip more directly in a way. John?
Yeah, John Nerva, could you want to ask that question directly? John Nerva?
Yes, sir. I've had a couple of cases with the CTA showed that the posterior clinoid process was hypertrophied and appeared to be excluding the aneurysm neck. In those cases, I elected to treat the patients with coil embolization, but I wondered how the panel would handle this microsurgically.
Well,
yeah, I think
go ahead,
the
Mike.
posterior clinoid can be an obstruction. It can keep your clips from actually passing the neck fully. So you have to be aware of that. But I think it just means that you work around it. You find a way to work the tissues into the blades. And it's never, in my mind, a reason to resort to a coiling strategy. You just have to do a little maneuvering to get the clip in the right place. If necessary, you can drill the posterior clinoid as well. It's something that's not so difficult to do. But yeah, I don't recall a single case where I've had to abort a clipping case because of the posterior clinoid.
Yeah, I share the same thing as Michael said. I would, along the same point, going to an operation without knowing enough steps to bail yourself from a difficult anatomy, that means you're not prepared. So you have to be prepared to adjust your technique and add steps to make your operation easy. This is the ultimate preparedness. I like to use the example, you don't go to war with one bullet or with one weapon in a way. You get prepared. You take a knife, you take a bullet, you take a machine gun. You have to be prepared for variations of the anatomy because sometimes the difficulty is anatomically, which you cannot predict pre-op. The variation in the anatomy can make an operation difficult, but your armamentarium of options should be able to overcome any difficulty. And that's what I mentioned, the going back to basics, understanding not only the anatomy, but the variations of the normal anatomy. If you look at Professor Yazaga's book, he talks a lot about variations of anatomy because he knew that if you know the variations, you are more prepared.
Okay.
Well, it's 6:30, and I think it's a good time to wrap this up. So,
I agree.
Ali, great seeing you as always.
Same here. Yeah.
Doing well, and John, thank you for broadcasting us. We appreciate it.
Yeah.
Okay, thank you for coming, and we look forward to seeing you
next Thursday, the same time. And we'll
Great.
be talking about MCA aneurysms.
Great. Thanks, gentlemen. We'll see you next week. Thanks, everybody, for coming. Okay, we stop recording.